Can't believe you're here. Born way too soon. I'm not ready.
You gave us all a fright. If it wasn't for the nurses and doctors who showed us what to do, I just don't know.
You were so fragile. They weren't sure if you would make it. But I held you tight and prayed with all my heart that you would leave.
I was so afraid to hold you. I'm so proud of you, my little gem. You are a miracle.
I couldn't believe it when they told me you were coming already. That I'd be holding you in my arms long before you were due.
I am a mom because of you. I can't wait to see who you become one day.
Hello, everyone, and a very warm welcome to you all to the Born Too Soon Supplement Launch webinar. Good afternoon, good morning, and good evening to all of you, depending on where in the world you are joining us from. Now, just slightly a month or two 2 years ago, we were in Cape Town at the International Maternal and Newborn Health Conference. And here we launched the Born Too Soon Decade of Action report. And I think this was a wake-up call, one that told us that progress on preterm birth had flatlined, and it connected the dots between stillbirths, maternal deaths, and the invisible loss of human potential. And one of the speakers, when we were in Cape Town, said something that has stayed with me ever since. She said, "This is not a moment, it's a movement." And the fact that we are gathered here again today, albeit virtually, across countries, across time zones, I think is a powerful testament to that truth. So I just wanted to start by thanking every single one of you for, not just for showing up once, but for keeping the momentum, running the race, and I would say continuing to carry this movement forward. And I think that's a very, very important thing for us. And today, we take the next step. So today we launched the Born Too Soon supplement, and this is a series of 10 papers that build on the call to action and is anchored on 3 Ps: progress, priorities, and pivots. And this is what we need to make now. But today it's also about a 4th P, power. So we have progress, priorities, and pivots, but we are introducing power. And which power are we talking about? We're talking about power of data, the power of partnership, and the power of people-centered advocacy. That is very, very important. My name is Mercy Juma. I'm a journalist, a strategic communication specialist, and a deeply committed advocate for maternal newborn child and adolescent health and well-being. And of course, when we talk about newborns today, commitment also to their families. And it's a big honor for me to guide today's conversation and be your moderator. So once again, welcome to this global launch of the Born Too Soon supplement. Now, it's also a reminder to us that preterm birth is not just a health issue, it's a human story and one that demands urgency, and that's why we're here 2 years later, and I really hope that we keep this movement even beyond this conversation today. So before we start, allow me to make a bit of, some housekeeping announcements. So first of all, we are offering live interpretation in French and Spanish. So please select your preferred language using the Zoom toolbar below. And then feel free to introduce yourself in chat. Let me see where you are joining us from. And if you can, just let me know what you think you want to carry away from this space or what brings you to this webinar today. And lastly, please start thinking of some of the questions or issues that you would want us to address in the next 1 hour and some minutes. And these are things that we could pose to the speakers and panelists that we'll be speaking with today. And without further ado, please allow me to open this dialogue. And we are really, really honored to hear from two leaders who are shaping global health, both in action and principle. And to start us off, here are remarks from Dr. Tedros Adhanom Ghebreyesus, the Director General of the World Health Organization.
Dear colleagues and friends, nobody should die because of where they were born. Yet today, many mothers and premature babies face that painful reality. In high-income countries, 90% of extremely premature babies survive. In low-income countries, more than 90% don't. Globally, 1 million preterm babies die each year. These deaths are largely preventable. They reflect gaps in prevention, early detection of risk, and high-quality care for mothers and babies. The supplement we're launching today expands on the work done in the landmark Born Too Soon report in 2023. That report took stock of 10 years of progress on preterm birth and galvanized a global call to action for maternal and newborn health. Partnerships such as PMNCH and the Every Woman, Every Newborn, Everywhere network are continuing this work by harnessing evidence, tracking progress, and sharing experiences. This supplement focuses on several key priorities: increased investment in equitable access to care, especially for marginalized populations and those in conflict zones, focusing on high-quality family-centered care, innovating through sharing tools and technologies, investing in locally led research, and better integration of maternal and newborn health into primary health care. Thank you all for your continuing commitment to ensuring that children born too soon do not die too soon. I thank you.
Thank you very much to Dr. Tedros. I think it's always so refreshing to hear from him. And he's one of the people who's been such a huge champion for both maternal and newborn health, and really, really appreciate always hearing from you. So next, we have Rajat Hosla, who's the Executive Director of PMNCH, one of the co-conveners of this webinar. And Rajat will reflect on the Born Too Soon movement and what this supplement means going forward. Rajat, welcome to the virtual stage. The floor is yours.
Thank you. Thank you so much for that, Mercy, and good afternoon, good evening, everyone. And thank you really for joining us from around the world. Colleagues, it's an immense pleasure to welcome you all to this important launch webinar today. And it is impossible, colleagues, to ignore the formidable headwinds that we face in the global landscape that we look around, the geopolitical, the geoeconomic shifts, and the challenges that we are facing are having a profound impact on the health and well-being of women, children, and adolescents, and particularly in the maternal and newborn health area. Despite the incredible strides, premature birth remains a leading cause of death amongst children under 5, and a stark and painful reminder of the work that still lies ahead of us. And as Dr. Tedros reminded us, far too many are dying of preventable causes needlessly. And as a partnership, we are very, very grateful for all of you for your contribution to the supplement, to this movement, and really for joining us today. As today marks a significant milestone in our collective journey, we are here to officially launch this supplement published by BMC Reproductive Health, and it provides us with a powerful new resource that builds on the foundational work of the original Born Too Soon report. This supplement, which highlights progress, priorities, and pivots for preterm birth, is not just a collection of papers. It is a vital tool designed to propel global efforts in preventing preterm births and improving outcomes for newborn and their families worldwide. It offers critical insights into the progress we have made, the evolving priorities, and the necessary pivots required to address this global health challenge effectively and critically in this challenging context of global aid cuts and other shifts that we are witnessing. The supplement highlights the importance of continuum of care and the critical connection between sexual and reproductive health and rights and prematurity. We know that gender-based and intimate partner violence, for instance, increases the risk of preterm birth. Fully upholding SRHR is therefore essential to preventing prematurity and its many consequences. Crucially, this launch underscores the power of partnership. The Born Too Soon movement, and as Mercy you referred to, at its very core embodies the spirit of collaboration, bringing together diverse stakeholders to drive change. It is a testament to the essential roles played by organizations, not just as partnership for maternal, newborn, and child health, the Every Woman, Every Newborn, Everywhere movement, but all of you. Born Too Soon would of course not be possible without working hand in hand with the World Health Organization, UNICEF, UNFPA for the development of the full report and the supplement, and a vast network of dedicated partners, including FIGO, London School of Hygiene and Tropical Medicine, the University of Western Cape, for this launch today. And you will be hearing from many of them later during the discussion. Our combined efforts across constituencies and regions are what truly make a difference in translating evidence into policy action. I wanted to take a quick moment to provide an overview of the papers in the supplement. The supplement includes 7 articles, including novel topics of rights-based approaches and intersectoral interventions to small and sick newborn care, and 3 commentaries, including the comment co-authored by the heads of agencies, that is World Health Organization, UNFPA, UNICEF, and PMNCH board chair. The development of the supplement includes 95 authors from 29 countries, 19 of which are from lower and middle income. And this is in the true spirit of partnership. A staggering 67 organizations are also represented in this authorship group. Kudos really to all of you for being a true partner. The development of this supplement reflects a labor of love and commitment to the cause. So let's seize the opportunity to engage with leading voices in the field, to amplify the importance of preterm birth prevention, and to help drive forward the global advocacy for maternal newborn health. Thank you, and back to you, Mercy.
Wow, thank you very much, Rajat. Really appreciate that. And before I go on to the next bit of this webinar, allow me to just give a shout out to all of you who are joining online. These more than 270 of you. Thank you so much. We have people from Uganda, Nigeria, USA, Zambia. We have somebody from, let me see, lots of Nigeria. We have Ethiopia, we have London, we have Australia and Austria as well. We have South Africa. Yes. Lima, Peru, Laura Altobelli, thank you so much for joining. We have Italy, and we have, oh wow, such a beautiful, beautiful representation of our, actually it's the universe, it's not even the continent. So thank you so much for joining. This is quite a diverse group of people representing all corners of this universe. And probably just a reminder again, that when we talk about preterm birth, when we talk about stillbirth, when we talk about, maternal and newborn health, this is not a siloed issue. It's not about where you are coming from. It is an issue that we should all be addressing, and Rajat has talked about that. So, we also have a chance to really reflect on how this Born Too Soon movement is not, is about amplifying both top-down leadership as well as grassroots momentum. And one shining example that we all should probably hear of and maybe emulate is that of Her Excellency President Samia Suluhu Hassan, the President of Tanzania, who, moved by just the personal experience of a grandchild born too soon, has led with so much compassion and policy reform. So again, a huge thank you. And there is a quote card on your screen. It says, we have built hospitals, health centers, and dispensary. Now our task is to strengthen what we have built and train staff to provide quality services to Tanzanians. It's a work in progress. We are not there yet, and we really, really appreciate powerful leadership, powerful women leadership that really is going to take us to where we ideally need to be, where newborns are not just surviving, especially those born too soon, but thriving, and also their families and the communities that exist where they are. So thank you very much. Now, allow me to go to Uganda. And we have a diverse, list of speakers who will be hearing from today in this webinar. Uganda is one country that's seen one of the fastest declines in neonatal mortality in Africa. And we have Dr. Richard Mugahi, who is the Assistant Commissioner, Ministry of Health. Dr. Mugahi, if you can just come on screen, please activate your audio and video if you are here. And we would love to hear from you. What role does accountability play in reducing preventable deaths? Dr. Mugahi, are you here? Great to see you.
Yes.
Hello. From Uganda.
Nice to see you, Marce, and thank you very much for this opportunity. I actually had the portfolio for maternal, newborn, and child health. The commissioner for those three very sensitive areas. I want to thank the organizers for this and to give us an opportunity to share the Ugandan story. I know it's going to be very brief, but I'll try to highlight the key areas.
I think we lost Dr. Mugahi. Your screen is frozen.
We have around 200,000 preterm babies. So we are privileged to be here, and our story for emphasizing survival and thrival of the newborn with special focus on prematurity or the born too soon babies has been reactivated with a lot of accelerated effort to ensure that we end preventable newborn deaths that are partly contributed to by prematurity or born too soon. In Uganda, prematurity ranks number 2, very close to birth asphyxia in terms of as cause of newborn mortality. And that is really a very big challenge. And we have organized ourselves to make sure we intervene and address or reverse this trend. Specifically, we've focused on areas of accountability, areas of strengthening coordination, areas of scaling up high impact interventions that are able to save so many of our preterm babies. And to mention but a few, we have an environment, a coordination environment that's very supportive. In terms of policies, we have the National Newborn Acceleration Plan being finalized. We have the newborn investment case. We have the newborn quality of care document. So many of the documents, including packages for care of the sick newborn. These have been adopted with the guidance of the international protocols, but purely domesticated and localized in the Ugandan context, being a resource-limited setting. We've also been able to improve coverage. We have a very good coverage of maternal and newborn indicators. For example, institutional deliveries in Uganda are at 86%. So we leverage the maternal health coverage to also improve the newborn coverage. But we had the challenge of our healthcare workers not being trained in newborn care and healthcare for the premature babies. And we have embarked on serious in-service training with the support of our partners to ensure all our healthcare providers who are handling the newborns at the preterms have basic knowledge through a comprehensive 1-month program, in-service program, about the care of the sick, small and the sick newborn. Uganda of recent has also introduced into the public sector, which is the biggest, commodities like caffeine citrate, which are very critical for the born too soon, the prematures, surfactant. We have free surfactant in our public health facilities, the highest level, which are like level 3. Level 3 facilities, which are regional referrals, have free surfactant bought by the government of Uganda. We've also had supplementary interventions like human breast milk. We've come up with, so far, have 2 human breast milk banks, but we also have organizations which are CSOs that move around to collect breast milk from mother being able to take it for screening and support the moms who don't have enough milk. Skin to skin have been some of the high impact interventions that we've been able to implement. We also adopted continuous learning. We have monthly webinars about newborn care coordinated through our National Newborn Care Working Group. Right now, we are running a campaign about birth asphyxia. We have an intervention framework for birth asphyxia. We have an intervention framework for prematurity. The 2 bigger killers for newborns have intervention framework. Also, the 2 bigger killers for mothers also have intervention framework. And we know how closely interlinked all these things are. We've also invested in community and public health to the extent that we want to do malaria prevention at community level, pregnant mothers being able to take their malaria prophylaxis so that they do not get preterms as a way of closing the tap. And as a matter of fact, we are one of the few countries that have registered a high maternal rate decline in the last 5 years. We registered 44% maternal death decline from 336 to 189 as of now. So moving forward, we want to scale what we are learning. We have invested in prematurity. We have a national day for prematurity that we commemorate and raise awareness. We are supporting lower primary healthcare facilities to be able to do the basic interventions and refer to higher centers, preterm babies. But also we have adopted, not yet scaled, but we have implemented a hospital to home follow-up system. After learning or doing adaptive learning and realizing that some of our preterms were actually dying after leaving hospital. Some of our newborns admitted would actually die when they go to their communities. So we have an audit system, we have a follow-up system that we are strengthening and scaling to the entire country. We have been able to achieve all this with our collaborative partnerships with all our partners, CHAI, UNICEF, WHO, and we seem to have a common consensus on supporting newborn as a community of practice. And we've also regionalized our coordination into care community platforms at regional level so that they can facilitate easy transportation, sharing of information, and efficient referral system. Thank you very much, Mercy.
Oh, thank you very much, Dr. Mugahi. And you are receiving a lot of compliments on the chat. Somebody said, amazing work, Dr. Mugahi. Somebody said, that's my boss, Uganda to the world. Yes, actually, it's really, really good to look at the countries that are doing well and see what we can app, how we can scale some of the issues that really will help our small and sick newborns to thrive. So well done, Dr. Mugahi. But before you go, and you can keep your video off if you have an issue with network, but I would really love to hear from you. You know, we have had instances in many African countries, and probably other people could relate, where priorities tend to change when there is a change in government. Uganda is going to go to the elections next year, but how do you just ensure that priorities, especially when we talk about small and sick newborns, stay consistent regardless of whoever is coming into power? Dr. Mugahi.
Thank you, Mercy. As a matter of fact, the newborn health in our National Development Plan 4 that begins 2025. It has been highlighted as an important area in National Development Agenda as an area where we need to strengthen outrightly. It is not the health sector. This planning happens at the National Planning Authority. So newborn health has been flagged as one of the areas where we need investment by the National Development Authority. And the targets for newborn health have been captured in the National Development Plan 4. And prematurity is one of the areas we are going to focus on if we are to reduce newborn death. We have a very ambitious target that is very closely related to the Sustainable Development Goal. So regardless of the government in place, this is already enshrined in a national document called the National Development Plan 4. The target is very clear. It's a shared position with a lot of intersectoral support, especially from the non-health actors, departments that are in charge of nutrition, the departments that are in charge of water, safe water, to ensure that we are able to deliver to our national target. Thank you for that question, Mercy.
Thank you. Thank you very much. And there's also a question which you don't need to answer now, but just to maybe you can reflect on that. And if we have enough time, maybe during the Q&A, you can jump in and answer this. Chimala from Malawi is saying, I would like to learn more about the breast milk bank. We are trying to establish one in Malawi. So maybe you can just think about, maybe the lessons you've learned establishing and running breast milk banks in Uganda, and what countries like Malawi could borrow, and maybe, both the lessons learned and, what has really worked for you, and if that could be borrowed by any other country. And this is a question that maybe could be picked by any other panelists who are conversant with the establishment and running of milk banks. So moving on, I know we are all itching to hear about, what this 3 and now 4 Ps are, progress, priorities, pivots, and really diving into the themes of the supplement that Rajat has talked about slightly. And I want us to move to our panel discussion, basically look at what progress has been made, what priorities must guide us going forward, and for me, critically, what pivots are essential. So in this next session, we are going to hear from Professor Joy Lon from the London School of Hygiene and Tropical Medicine and Nest 360. And Professor Joy was a lead editor of both the Born Too Soon report and also the supplement. And then we also have Dr. Anki Hara, who's the president of FIGO and a board member at the Partnership for Maternal, Newborn and Child Health. And we have Doris, a very good friend of mine, Doris Molel, from the president of the Doris Molel Foundation from Tanzania. And we start with you, Professor Joy Lon. Really nice to see you as always. Such a huge champion for this cause. We are so lucky to have you, honestly, as part of this movement. And Joy, you've led and literally studied this space for decades. So what does the data say, and what policy shifts do you think are essential right now to change the curve on preterm birth? Please take us through this, and the floor is yours. Thank you.
Thank you, Mercy, my friend. Such a treasure to see you. We miss seeing you on the BBC. And thank you that you remain a champion for women, children, newborns, and born too soon. So I'm a small person, but I stand here on behalf of 95 authors, and it's wonderful to see more than 350 people online. So this set of papers is only possible because of the work of all of you. And also want to really thank the BMC team and PMNCH for their support. And the power of this is a movement. And a movement comes from people who are different. We have unlike minds, we need to get beyond our bubbles, and we need to be brave about what pivots need to happen. But what has held us together, I think, is a shared purpose. And that shared purpose is that every woman, every newborn, every child should have that opportunity to survive and thrive. And I thank my brother from Uganda for eloquently describing that. But here today, with 5 years to go in the Sustainable Development Goals, we still have just over 250,000 women dying giving birth. We still have a shocking number of deaths of children after their first month and before their 5th birthday. And here in the middle, close to this critical, vulnerable time of birth, we have 2.3 million neonatal deaths the first 4 weeks after birth and 1.9 million stillbirths. And both of these have flatlined at global level for the last 3 years since the report came out, and we highlight that lack of progress. So tomorrow there will be an important seminar on standing up for stillbirths. Today we want to look together at women, newborns and stillbirths. And this is a total of around 8 million deaths. And this 50% of them happening closer to birth have the slowest progress. They're the most vulnerable. And most vulnerable, especially to the polycrisis that Rajat has brought to our attention, whether that's climate, conflict, the geopolitical shifts we see at the moment, all of those hit hardest on particularly vulnerable newborns. And as Mercy has said, over the last decade or so, we have had this increasing data. And there is no doubt that this is a very big problem. We have substantial data. And we're not going to spend a long time on this webinar admiring the data because we want to get to the actions. What are the pivots? How can we go faster for women, newborns, and children? And it will be impossible unless we go faster for preterm birth. So if we move forward into what we have seen in this movement over the last decade or so, we had a report in 2012, at which point preterm birth had become the top cause of child deaths, but we didn't have estimates. Those were the first preterm birth estimates, showed a problem in every country in the world. In 2023, we had the Decade Report launched at IMNHC. And in that report, we really resonated. And, you know, I call out journalists and families who were involved because all the stories around the world really led with what this means on the human side, as well as the numbers. And later in this webinar, you'll be hearing from Doris Malal and the GFCNI team who have ensured that now World Prematurity Day becomes an official UN day. And we thank Dr. Tedros and all involved for making that happen. So now we have these papers. Why have papers when we had a report? So as you heard from Rajat, there are 3 comments. High-level leaders, Dr. Tedros has spoken beautifully to why that matters. Also community voices, and we will be hearing more about that. And then an overview from the Born Too Soon editors. And then these 7 papers, of which 2 are particularly novel and powerful, rights and respect, and then also the intersectoral side. And we encourage you, please download and look at these papers. And what's new? What's changed since the report? Well, we have data updates. Sadly, not very big change in progress. We have additional evidence. WHO has continued to bring out important guidelines we want to underline. There have also been geopolitical shifts that we need to face, as Rajat has said. And most of all, these papers try to give us an evidence for implementation and investment to go faster together. So I want to give you a whistle-stop tour just on the headlines of those papers and encourage you to dig into them. So first of all, something new. As Dr. Tedros said, we have married together the Every Newborn and the Ending Preventable Maternal Deaths to be every woman, every child, everywhere. We hope soon to have every newborn everywhere. I hope soon to have the child as well. And our common passion is to see that every woman has an opportunity to choose whether she should be pregnant or not, that also we have effective and high quality antenatal care, care at birth, care after birth that looks after the mother and the baby and looks at these social determinants. But we cannot provide empty care. We could reach 90% of antenatal care, but what must we have in it that will reduce preterm birth? That is what these papers will help you to find. I want to highlight from paper 1, new data that has come out since the report. What you can see here is the global burden of disease. This is every condition through all ages in the whole world. Number one in the year 2000, neonatal conditions, really driven by preterm. Still number one. If you look at all the other rankings, they have changed. NCDs have come up, infections have tended to go down, but neonatal conditions is up there. And I want to underline, it's not that we've tried and failed, we haven't tried enough. So the biggest pivot is that we can no longer stay silent. In many ways, we're too nice. So for you who are parents and professionals here, we need to stand together and raise our voice more, because this is not a special small issue. It's actually at the top and is not at the top of agendas. So then if we look at paper 2, this refreshes the important numbers that we already put out. So still, every country and every region has a problem with this. 13.4 million babies born too soon. And of those, 1 million are dying. And the 1 million who die is mostly in South Asia and Sub-Saharan Africa. And most of those are preventable. So this data, and you can find a web annex for paper 2 that gives you your national data and your rate of change. Please use it and hold people accountable, because this is why this is urgent. Why is this still at the top? It's because we're flatlining. So preterm birth rates around the world have flatlined over the last decade. I'm sure there are things that we've done better and maybe some things that have counterbalanced that, such as climate change or conflict. But we must go faster. And so the paper 2 in this series gives an updated synthesis of risk factors. What are the things that we must address? And in a context of cuts on, for example, demographic and health surveys, what are the data elements that we can put into national routine data so that we have the data in each country, nationally and subnationally, to use? So please look at that and use that in your country and to go faster. So how do we go faster? Let's focus on the actions. We have these 2 tracks. The first track is to prevent preterm births. Utterly critical, and this is intrinsically linked with the rights of women and the care we give to women, and particularly those who are vulnerable, older women and adolescent girls. And then the second track is to improve care for those babies who are born too soon. What is it that we must and can do, and how do we make that work? And then in between, how do we do better to manage preterm labor? So an important slide here on preventing preterm birth. And I want to salute FIGO, Bo Jacobson, and also the WHO RHR unit for leading on this paper. Women's sexual and reproductive health, preconception care. We will not succeed if we wait until the moment of birth. We need to start earlier. We need to look at antenatal care, not just coverage, but quality, especially for infections, and better obstetric care, for example, for preeclampsia. We have many things that we can do to manage preterm labor better, of which the highest impact is antenatal corticosteroids. And we also need to look at intersectoral, and that's a new angle that I will come back to later. So this is critical. We can and we must do better. And we can do that within a lot of the health system packages that we have, but we also need to look beyond the health system. So then if we move forward into the second pathway, 13.4 million babies that are born too soon. And Dr. Tedros highlighted this inequality around the world. For a baby who's less than 28 weeks of gestation, 90%, more than 90%. So even in my days, many years ago as a neonatologist in the UK, we were at 95%. But in our low and middle income context, these babies, maybe less than 10% of them will survive. This is like the gap we had for antiretrovirals 20 years ago. And the world came together with ambition, with noise, with action, and changed this. And we must and we can do that. Just because these babies are without voices, because their mothers are often without voices, means we need to stand together and communicate better. That's the bad news. The good news is we have a clearly defined package by WHO, and we need to keep that small enough. If we start adding expensive things like surfactant, we risk making that package not reach every district. And to do this and change it, we need a core package with every district with quality and equality. And then if we look at the learning for that, so that this is something that even in the 2 years since the report has accelerated so fast. So we have data that shows which babies are most at risk. And here, sometimes birth asphyxia is misclassified as preterm because babies don't breathe at birth. So acting quickly at birth and providing effective neonatal care is critical. And often we waste energy. We reinvent training materials, we reinvent data tools. Please, I encourage you for us to go faster together. Let's not waste. Let's use, adapt, share tools and join this community on the Newborn Toolkit where we can make that happen faster together. I want to move out of the health sector now and into intersectoral. So this is so important. And even in the 2 years since the report came out, more evidence has come. And I salute particularly Etienne Langlois from PMNCH and his team who have led really thoughtful work on this. Not just to admire the problem around the 5 E's of intersectoral, environment, economic, emergencies and so on, but what can we do? So please do look at this paper, look at the things you can do and act on it. And there are things that we can and we must do because women and babies are most vulnerable in these situations. And underlying all this, really critical to recognize rights and respect. And this new chapter has done the first mapping of human rights instruments to preterm birth and maternal and newborn health, showing synergies, opportunities, tools that you can use to hold governments accountable. And we recognize that rights are increasingly at risk. This paper also gives a very thoughtful person-centered framework. And I want to really salute all the authors on this, and particularly Mary Kinney, who brought very different voices together to land something that is actionable and that we can take forward. And we need to stand up in these days for rights, for respect, to empower voices to really make a difference. And we need to be braver. Maybe we're being too nice. So I want to land in on this. We know that we can make a difference. It's not that we've tried and failed. We haven't done enough. So what these pivots show is that we must invest more. And maybe the moral argument is not working so well, but we can make the argument of the return on investment for your human capital, for your workforce, particularly for Africa, where Africa is now the only expanding birth cohort for the whole of the world. For implement, we actually need to put into practice. To integrate, we're not competing with each other, we will go faster together. And to innovate better. One of the important messages out of this is the human face. It's not just big numbers. Many of you on this call yourself will have been born preterm. We will be hearing from Doris and others later. And there's really valuable learning in this comment on how do we enable, in an ethical way, voices to be powerful, but also respected, not to use people's stories. We learned so much in doing this together. And I want to end with this. Yes, we need the voices of families, communities. We need all of us to elevate that, but we also need our leaders to stand up. So we started with the President, Her Excellency of Tanzania, and what she has been doing to implement, to invest, to innovate. I want to really highlight India with 23 million births per year that from their own government coffers are putting more than $1 billion a year into providing effective neonatal care and also looking intersectorally. All of us have a role to play. This is a movement, not a moment. Please let us be braver. Let us use the data. Please use these papers and join us to bring change. Thank you.
Oh, thank you very much, Joy. There are a couple of people who are asking about where we can see the papers. There's a couple of people, including Etienne, Amy, and colleagues from PMNCH and other co-conveners that have put on the chat links to where you can access all these papers and also other material, including websites to some of the organizations that are co-conveners or champions of the Born Too Soon movement. Joy, thank you so much. And, you know, everybody who's spoken, you included, has talked about each one of us having something or a role to play in this. And the papers really explain what each one of us can pick and run with. So please, I would encourage you, go and read those papers and see what you as an individual or as an organization can pick and learn and do and implement. There are a couple of questions that are coming in. Joy, I'll come back to you a bit later with a couple of questions that you can answer. And please feel free to use the Q&A section to put any questions, even on chat. If you cannot find the Q&A, but I would appreciate if we use the Q&A slab, but you can also put it on chat. There are a couple of colleagues who are monitoring and will pick any questions you have that you would like Joy or any of the upcoming panelists to address. Dr. Ann Kihara is also online. Ann Kihara is the president of FIGO and a board member at PMNCH. Dr. Ann, it's really lovely to have you here, and I hope you are well. Nice to see you.
Great to see you.
You know, Joy has given a very, very comprehensive breakdown of what these papers are about. And one, she ended by saying that we need the leaders to stand up. And I think the question probably marries in very well with that statement. You know, how can we push for policy and investment? Those are very, very key issues. And push for what can empower health workers to act. What policies do we need to talk about and to push to just ensure that we empower health workers to act, and all this while ensuring that the rights of mothers and newborns are respected and upheld?
Thank you very much, Mercy, and really thank you for the speakers who've spoken before me. And I want to start with sensitizing all of us. Every 2 seconds, we have a preterm born. And then every 45 preterms die every minute. 2,700 every hour. I think if that doesn't touch all of us, we really need to wake up. And I want to put the perspective as a healthcare provider who is in leadership and a healthcare provider who's also an implementer of services, and bring up some of the things that really are of concern to me. I want to start with where it's fundamental, the skilling of the healthcare worker. Yes, we have talked about the newborn, but you must have the maternal newborn dyad to work together, which speaks then to the two of us, or those two disciplines, really coming together and synergizing efforts in maternal newborn, and therefore extending onward in the continuum and with the life course approach to healthcare. That is one. Now, in the clinical care, what should we really be looking at? The normative environment that does exist. What is your legislature? Highest attainable standard of health, including reproductive health, respect for human life. Policy environments. What is your policy? Not just in reproductive health, but even looking at it in the context of adolescents and youth, in the context of humanitarian crisis. What are we saying? The policy environment, the access to a robust health system, guidelines, and how soon do you update the guidelines based on what is coming out as evidence best practices? How soon do you do those updates? Is it 5 years? Is it 2 years? Or is it on a rolling basis? What is, as WHO calls, the living guideline? But beyond even the update, what is your distribution, dissemination, and subsequent implementation to that care provider? So launching may be one thing, but implementation is really where we need to focus. And this is where leadership becomes extremely critical, and the coordinated approach in which to improve access and equity, even within the policy environment. What is your equity aspect? And then where do I do basic level of care, comprehensive level of care, critical care? And what then speaks to your referral mechanisms? So what does this point to me as a clinician? We should be constantly having reskilling and upskilling. I'm using those two words very clearly. Reskilling because there's some skillings that we need to unschool and implement. Upskilling for the clinician of today. You have heard about humanitarian crisis. You've just heard from Joy Lawn, about the issue of multi-sector. I keep talking about the healthcare provider fit for purpose within the globalization agenda. But again, the same healthcare provider needs to also go beyond their clinical expertise. Look at leadership and clinical governance, their motivation to be at work, the team spirit that must be there, the work culture. And I want to really emphasize the work culture that does exist in our environment, mentorship, and again, advocacy, and also accountability. I think these are very, very critical steps. But I want to rivet this conversation a little bit more and look at the rights, respect, and support now of the healthcare worker. What are some of our issues? What is the working environment you have provided healthcare workers? To reduce medical errors, to reduce burnout, to reduce absenteeism, to improve the quality of care that Joy Lawn really wants us to provide for that newborn. What is the remuneration of that healthcare worker so that staffs are retained? I must say we are having a mass exodus of clinicians and experienced clinicians moving into the diaspora. What are we doing? Yet we're still saying Africa has got the bigger burden of births that are happening. How are we extending remuneration across the board from those who are doing community health promotion to those right at the tertiary and even the quaternary when I speak of critical care? Protection from violence and discrimination, professional development and training, legal and professional autonomy, participation in decision-making, and continuous research and development. And here I really want to emphasize, a lot of doctors would want to participate in research and development, but what is the protected time? So with that in context, I then said, okay, Anne, you can't complain all the time. What can you really give as a kind of response framework? Number one, strengthening national leadership in cahoots with implementers and not at implementers of service delivery. Making sure that we enforce also the rights-based for workforce policies and integrate workforce well-being for maternal newborn health, optimal quality improvement initiatives, involving them even as we cascade different delivery, service delivery models like the midwifery care model or the community health model. Standardize approaches so that we can scale those up. And I like the fact that Lorne even spoke about have core functions. You can add the other layers, but can we have a minimum package that we should be able to say, this is essential, this is then emergency. Investing in human resource standards and norms, those should be respected. The other is the healthcare provider rights charter. It doesn't exist. What should we be doing? Thinking through that should constitute the healthcare provider's rights charter. The next thing is integration of program design for high impact. This is where we're looking at multidisciplinary, multi-sector, leveraging on technology for access and equity, scale up of domestic resource mobilization, robust healthcare system and referral networks. Data, data, data. That really should be able to tell us, how are we doing? These papers that have come out are clearly reflecting the data, but how are we using it, and how are we empowering clinicians themselves to conduct implementation research, de novo research, and also now using data modeling to give predictive and precision care. These are skills that we certainly need to be provided with. And then having really strong, robust networks, not only for quality of care, for interrogation of policy, but also across professional disciplines to optimize our outputs and to engage communities. We have always siloed doctors in one block, policymakers are there, communities are on the opposite end. We need to have an intercollaboration between us all, so that at the end of the day, we have what I call the advocacy and accountability, so that we can invest in this precious little human being for human capital for tomorrow. I'll leave it at that for now.
Thank you very much. Thank you, Dr. Ankihara. Very, very passionate. And I was just about to ask you if you could speak more directly to the realities of health workers and what they face. But I think you've addressed a little bit of that, and also gone ahead to give us, what the future looks like, what we should be looking like, including mentioning things around remuneration, development and training, research and development, and most importantly, I think for me, the Healthcare Providers' Rights Charter. And maybe you can come and speak a bit about that during the Q&A. But allow me to move to Doris Molel from Tanzania. When you talk about including everyone in these conversations, Dr. Ankihara, then there's no way we can do this without really, ensuring that families are truly included in the care of small and sick newborns. What must we change, Doris, to ensure that in this journey, and as we do this advocacy, that we ensure that families are not just by the way, but they are really put at the center of the discussions and the policy and the decisions that we make in the care of small and sick newborns? Doris. Doris, you are still muted. Sorry.
Yes, Mercy. Thank you. Happy that we have more than 350 people listening to us. This at all brings what it really means to have a collaborative approach to take all the good information and disseminate it to where we are. So if I heard you correctly, for me, number one, I think the best practical thing to have as a support from families and member states, countries, and wherever we are, it begins with a political will. So I take in the consideration of how Her Excellency Samia took in and understand what it really means to invest in saving lives of the born too soon. This really reflects into the 11 years that Doris Moral Foundation started. It was never a national agenda. It was never a national priority. And that's where you see in the role of policy and advocacy, something which is really underestimated, something that's really underfunded, and I would say undersupported, especially when you're around technical people, when you're around most people who are really looking to how best writers and conveners could take in the consideration of understanding how best local champions can be very influential in changing the narratives and changing the culture norms and the barriers that are hindering the progress of saving lives of this born too soon. So taking a reference of what is happening in Tanzania, it was just a matter of the Ministry of Health understanding, the members of parliament understanding, and also the community understanding on what this really needs to be done. So if I refer back to 10 years, in most places where I would walk in to even ask for sponsorship, people would quickly say, what is premature? And why do even babies come too soon? And why do we even have babies who are born with low birth weight? and what's this whole small and sick newborn babies are like. So it was really a challenge. You would walk in rooms, people are really educated, of course the ones who are non-biological people. I'm talking about leaders who are in the corporate sector, the private sectors, who are not even well affiliated with the health sector. They wouldn't understand what this means. Having a collective support from journalists, having a collective support from parents who have gone through it has really changed our ways of thinking. So it was us working with journalists, working with parents to raise awareness about what has really been happening in their personal life, sharing their stories. It didn't just happen when we were commemorating the World Prematurity Day. No, it started from getting to radios, getting to different communities, visiting, donating. As we donate with specific local leaders, members of parliament, representing a specific constituency. So slowly we were penetrating the world of political will. So as it got up, we even got to have a time to request a meeting with the vice president, who's now our current president, understanding why this happens. But even when it got to her very own situation, when her grandchildren were born too soon, she was not afraid to say it because she was already involved. She already heard about this for almost 10 years. So it's a tiresome work that really involves local champions being well hugged with appreciation, being well hacked, with being given with getting platforms where they can speak, where they can be supported financially to move here and there to talk about the most key challenges that are affecting these parents. So it's more of a collective approach, because Doris Small Foundation's win in changing the narrative and making it a national agenda, it was involving the decision makers, the beneficiaries, of course, who are the affected families, but also involving the healthcare workers. Even how we work with pediatricians, we've been working so closely with the nurses to share in what are supposed to be done, so that when political leaders go on stage, they know what to speak, where, and what exactly should be addressed from a family level to a national level. So with my best understanding, if we get our leaders to understand, they will budget, they will talk about it, they will make it as a story wherever they go, and they will make it as a personal story. Especially for we sub-Saharan Africa, it's best to make a politician understand this is your voting card, and the community will understand you when you do A, B, C, D. So that was the path. It wasn't easy. It took us 10 years, but here we are. Even other African countries will keep on learning of what is happening in Tanzania. Now, whenever the president goes to any hospital, even if she's launching, she would be asking for where is a neonatal unit, where are the premature babies and low birth weight sitting. The same goes to Zanzibar, because Tanzania, we are Tanzania. Even in Zanzibar, the president of Zanzibar has really done a dramatic change. And this was just after us sitting with her, with the First Lady of Zanzibar, sharing our biggest concerns of what really matters and what should be really of a big change. So even the bigger hospitals that are being built now in Zanzibar are really creating more spaces for premature babies, something that was really not there. So what is existing was more of, reworking the units that existed and several supports from donors. But now we are seeing actually even creating more spaces through the new construction. That means the engineers are sitting, the ministries are planning, and involving everyone at a government level. So that's what I should say.
Thank you, Doris. So basically political will and really ensuring that we voice what needs to be voiced and bring everyone along. And you've mentioned it's been quite a journey for Doris Small Little Foundation, 10 years. That's, quite some mileage, to be honest. And you're doing really, really impressive work. But the landscape is changing, Doris. We are seeing, or rather we are sitting in a very, very interesting times in the development space. There's a bit of donor fatigue, and we are also seeing an issue now with the funding landscape. All these cuts that we are seeing, does it make you uncomfortable? Are you scared? And what would be your message, especially to policymakers, to partners, to really ensure that, the strides that you've made as the Model Foundation, or even that we've made as a movement, do not fall off the radar? Very, very briefly.
Thank you, Mercy. Well, definitely key number one is to make government scale up. is to take the voice, leave it to the government so that they scale up all this beautiful intervention. And it was scaring me. That's why I was not sleeping until I could see the World Prematurity Day becoming a global day. And it was not just a quick thing that was happened in one day. It took us 3 years. We wrote to Dr. Tedros, and he was very happy and excited to support us. But then we got to see him in person the coming year. Then he gave us the steps towards winning that. But of course, it had to involve member states. So this is where our Ministry of Health come into place, working with the Ministry of Foreign Affairs and all other member states and non-profit organization, non-state actors. So we came together to have this day come into practice. Why am I so happy? And I'm seeing that reality coming to our main target as a goal. It's because the voice of a woman who just started the organization, having this premature day celebrated in different countries alone, now took it by Tanzania and make it as a global. So what does this mean? I'm seeing a dream of we champions are leveraging the efforts of making countries now invest, put budget, do research on their own budget. So I'm expecting member states to incorporate budgets of investment of care, research, and all aspects along a line, maternal and child health, supporting born too soon babies. So that means we no longer have to think of where is the funding coming from. Of course, we are donor dependent. Most of countries are donor dependent, but having it scaled is what this day would mean. It means that countries are now going to put their very own efforts in saving lives of these born too soon babies. So this day is a mark of that vision that I got scared of.
Thank you very much, Doris. And I think you say probably things that really resonate from us, especially when we sit down here in the mother continent, and it's a wake-up call to all of us. I'm seeing people from Nigeria, Zambia, other countries in this beautiful continent of ours. And when there's this shake-up around funding cuts, it's really a wake-up call for us to, have our leaders and us ourselves be accountable into what we really invest in, how we budget, how we prioritize our resources to ensure that we can at least be self-sustainable. Of course, people would come in and help, organizations, other countries would come in and help, but it's really, really important for us as countries, especially in the continent, to really put in the effort and the resources to ensure that the strides that we've made, thankful also for everybody that has come along with us, are really not just washed down the drain. So thank you very much, Doris, for that. I have a couple of questions coming up. There are very good questions on the Q&A. I'll get into that a bit. But before that, let's have a little breather. And this video is coming up. Joy mentioned that, the supplement has been a powerful feat of partnership, bringing together, about 95 authors from 29 countries, more than 29, I think, around the world. And it will be great to hear from just a few of the contributors who will share their perspective on what it will really take to safeguard the future of preterm birth prevention and to strengthen maternal and newborn health globally. Let's take a look.
One priority action that's needed to accelerate preterm birth is to implement women-centered care and a rights-based approach, one that considers the rights of women, newborns, and healthcare workers. We also need to accelerate action by implementing intersectoral actions, ones that consider the environment, education, in addition to healthcare. Thank you.
Nothing exemplifies the SDG agenda better than the care of small and sick babies, because it includes both survive and thrive. And the single most important thing we need to do for it is elevate the level of ambition, both in planning and in financing. Moving away from piecemeal projects to systematic scale-up led by government. It's like a journey. You need to know where you want to go and you need to plan it well. There are no shortcuts. Many countries have done it and many more are doing it. And I'm sure together we will do it sooner than later. Thank you so much.
For babies who are born too soon, there is an urgent need for prioritization around innovations, both for the prevention of preterm births and for quality care of these preterm babies. This should involve systems that are locally driven to fit the local context. Example, CPAP machines that are manufactured locally to prevent the death of these babies. Thank you.
Wow, thank you so much. Progress, priorities, pivots, and the fourth one, power. Now, let's hear what you say. And even as I go to the questions, I have a question for you. Just put this in the chat. We have been here for, or rather, this webinar is supposed to take 1.5 hours. That's how many seconds? Probably around 5,400 seconds. Yeah, please confirm that for me. How many seconds are in 1.5 hours? Drop that in the chat. But now let's go to the questions. There is Daisy Chelagat, who is asking a question around artificial intelligence and predictive analytics in healthcare. Are there any examples of predictive models for preterm birth currently being used in clinical or public health practice? And should also be interested in hearing your thoughts on feasibility, acceptability, and equity of applying models in low and middle income countries, especially in settings where data quality and infrastructure might be limiting factors. Professor Joy Lorna, I would love you to take this, especially the one around data and the feasibility of applying such models in low and middle income countries, and specifically because you have been a great ally in countries like, South Sudan, your birth country. So if you could take that and also probably address, issues around AI and predictive analytics.
Thank you, Mercy, and thank you for all you do for South Sudan. As you know, I was born just over the border and we need to stand up for it. Yeah, thank you for the question on AI. I think I will start with saying we do have the data to use even without AI, so please don't be paralyzed by that. For each country, we have numbers of births born preterm, we have rates, we have deaths, we have maternal death estimates. So we should use that now. Then at the individual level, we also have clinical algorithms. Dr. Anne Kihara talked about the importance of a skilled obstetrician and midwife who can see when women are in preterm labor and also predict some of that risk. There are experimental work ongoing, both on better biomarkers and also on AI, and then combining AI and biomarkers. And, maybe that has some hope, but I think what we need now that we can do for every one of those 13.4 million born too soon is to do better with the data and the evidence we have now, to do better care for those women and for those babies. And particularly if you look at the second paper on data, we highlight missed opportunities in current health management information systems, such as the such as the district health information systems, which is in 80 countries. There are things that we can do now to improve and to use that data. There are also innovations of electronic data, with the possibility of adding AI, for example, for other specific things like looking at hospital-acquired outbreaks for women or for babies. So my message would be use the data we have. Yes, we need to innovate, but most of all, let's act on providing effective, high-quality care now and use the data to hold people accountable. Thank you.
Thank you, Joy. And I'm not sure we will be able to go through all these questions, and definitely co-conveners, PMNCH, London School of Hygiene and Tropical Medicine, all the conveners. I think this is not a conversation we have in 1.5 hours. We probably need more time to go through all these, and please, let's talk about that. But there are questions that Mary from University of Cape Town, and then we have Etienne from PMNCH and Bo from FIGO. are monitoring as well, and probably some of them will be answered in chat. I may not be able to mention that, but just a shout out to the three who are also monitoring, and we'll take some of these. Now, there is a question on, and Dr. Ankihara, maybe you could take this. Are milk banks culturally accepted, and are there any religious concerns associated with it? Joy is also typing on that, but if Dr. Ann, you can just jump in very briefly and say, like, what have you heard? Are there religious concerns? What are cultural elements that we have to maybe think about when we talk about milk banks?
Certainly, and there are cultural concerns. There are also medical concerns, because we also do know there's some diseases and there's some medications that can be propagated through milk. But we still say this is better than the milk supplemental products, because it is humanoid, it is ours, and we can actually be able to treat it effectively to be able to then provide it to the baby born too soon. But what am I trying to get at? I think the most important is the health literacy of communities. We give them first and foremost a listening ear, because we need to also first and foremost understand what do they have and what do they perceive and what do they know, before then educating them so that we can come to a common understanding. Because I know even in Kenya, we do have a milk bank. But initially it was treated with, this can't happen. But today it's still robust and running. So it's a way of going forward, but I think the literacy must be based on a give and take with communities that we work and interact.
Great. And now that I still have you, there's Dr. Joy who is asking, can you please talk about, can Dr. Ann talk about the Healthcare Workers Charter and how many countries have started implementing it, and what has been the experience for other countries to learn from, especially with the current HRH gaps? So very briefly again.
Okay, very briefly. In my travels, the only place where I think they're beginning to try and really emphasize on it is in America through ACOG. But a lot more of us have been taking little pockets of it. So I think there's room for us to consolidate what would then be the health providers charter. Just to give some examples, some of us are involved in policy and decision-making and contributing to governments. That is one arm. And I think that should be a standard where healthcare providers can be at the table, and particularly through your professional societies. The second is certain context of mental health. We saw this a lot, particularly after COVID. So we are taking little pockets. Accountability is a third one. Continuous professional development and opportunities even for growth is yet another one. The other is collective bargaining. So I'm a gynecologist, Lon is a neonatologist. What can we do together to actually optimize patient outcomes, as opposed to in siloed approaches? Non-discrimination and equal opportunity, wherever you work, whatever a situation that you're confronted with. Here I can quickly think of those in humanitarian crisis. What kind of environments are we providing for them so that they're able to optimize functionality, but also taking care of their welfare? They are parents, they have children, they probably are even pregnant for some of the women. What are we doing for them in such situations? So we have pockets, but we haven't consolidated it, Joy. So I think there's room for that to work as a collaborative.
All right, great, thank you. There's a question around, let me see what this is. It's been moved to, okay, there's, okay, Mary Kinney has answered this. Thank you very much, Mary. So let me go to the open questions. There's one around evidence around impact of high and indicated C-section rates on newborn outcomes and recommendations on this front. And they give an example. More than 80% of births in private sector in some areas are via C-sections. Considering that 50% of births in these areas are in the private sector, what actions should be prioritized? I feel like, Annie, you're the best person to answer this, but is Bo here? I'll give you like a minute to tackle this. Bo from FIGO, if you can just put your video on and answer this live about C-section rates on newborn outcomes and recommendations on this front. Hey, Bo, good to see you.
Hi, do you hear me?
Yes.
Yes, loud and clear.
Yeah. I think that in FIGO we are working on the high cesarean section rate on many different levels. And we really try to address this in different ways. It really, and also give guidelines in different ways. There is also a new Lancet commission that is really focusing on this on the global level. One thing is to have registers, so we are able to notify and follow the kind of developments over time. And we also see that iatrogenic preterm birth due to previous preterm birth and also the complication with kind of placenta accreta syndrome, that the placenta is growing in, is increasing. But I think that it needs to be quite policy change in many ways, and support of the healthcare workers to be able to handle the situation, and the quality of those cesarean sections that needs to be done are very important as well. That is a short question to a very complex and big thing.
Mm-hmm.
Previous cesarean section is related to preterm birth. That is obvious.
Right. Thank you, Bo. I'm a very big proponent of kangaroo care. And Joy, remind me that when we were in Cape Town, we tried not to say kangaroo mother care, but kangaroo care, to ensure that we incorporate even, the fathers and other people in the community. But there's a question here that from Christina. She says, given the focus on human cost, empowerment of women, and ensuring use of an inexpensive package, is there any discussion on reviewing the idea of continuous kangaroo mother care as the gold standard in favor of low-cost, context-appropriate innovations, thereby valuing women and mothers' time, the ability to contribute to their families and communities, and giving LMICs technically appropriate tools? Joy?
Thank you, Mercy, and thank you, Christina, for the question. Just to reflect that now with quite a lot of randomized trial evidence of KMC being better than incubators and better than other care, WHO has recommended that as the best for everybody. So, for example, I examined a PhD in Karolinska in Sweden, and that is the norm. So it's not poor things for poor people. The problem is how to do it. So in Tanzania, where I'm sitting for 6 months, most newborn units are very small. There's no showers and toilets for women. So if we want women and dads to do KMC, we need to be respectful of thinking about the space and supporting them properly. And then we do need additional innovations, for example, transport incubators when the woman is not stable enough, and other things like that. But we shouldn't downplay the impact and value of kangaroo mother care starting early and for more hours. It's best for the woman as well. It actually is shown to be better mental health. It's better for the baby's survival. It's less infections, and also better thriving, as Gagan noted earlier. So we need the balance. Of course, we need local innovations, and there's many other things we need as well. But we shouldn't downplay the strong evidence and value add of kangaroo mother care. Thank you.
Thank you very much, Joy. And yeah, we could talk about this for long, like I said, but unfortunately, we only have about 6 minutes to end this webinar. So at this point, please allow me to hand over to Rajat again to give us a final reflection and to outline the way forward. Rajat.
Thank you. Thank you for that, Mercy. It's been a wonderful conversation, and I do have to applaud over 350 individuals who joined, and several of whom have stayed through the last 90 minutes. And, we do organize several of these policy dialogues, webinars, and I'm deeply impressed with not just the participation and the range of individuals who are on the call, but just about the content of our discussion as well. And it just shows the deep levels of commitment to the issue that we are talking about as a key to the global development and health agendas. As I spoke earlier today about the Born Too Soon movement and the launch of this supplement as a marker of a crucial point in time for maternal newborn health, the conversation today has demonstrated the power of harnessing partnerships for change. And our speakers have really reaffirmed this idea. And I do have to say, Joy and everybody else referred to the challenging time that global health is going through and the imperative and what you showcased, how we can keep these issues as critical to the larger global health discourse. From high-level policymakers to grassroots civil society movements today, we have seen how change can happen and the impact we can make when we work together. Now, we just need to make sure that we sustain the momentum and that the decade ahead is better than the decade behind us. I want to really thank our panelists today for giving us a robust look at where we are on the preterm birth and stressing that while the situation is urgent, the outlook is indeed hopeful. And really thank you to you also, Mercy, for such beautifully curating the conversation over the last 90 minutes. It is clear that we live in uncertain times for global health, but we also know what's at stake if we don't put into action the priorities that different speakers and this series outlines. The path forward demands a collective focus on implementation, which means translating our strategies into tangible investments and actions on ground, ensuring every policy and every resource reach those who need it the most. Crucially, we must empower country-level leadership, like those leaders who spoke here today, but also those who are not on the call, but doggedly working on these issues time and again. Sustainable change blossoms from within, driven by local expertise and tailored to the unique context of each nation. By supporting and strengthening these national efforts, we can build resilient health systems that truly serve their communities. And I do want to, at this stage, also give a big shout out to the Global Leaders Network, which is curated by His Excellency President of South Africa, and many of the countries that have been showcased in this special series. The heads of states from them, including the President of Tanzania, a part of this Leaders Network, speaks highly of their commitment. We now need to translate that into action. And therefore, we must empower the country leadership to continue doing what they are doing, but do more with less that we have available to us. Furthermore, our discussions have highlighted the critical role of domestic resource mobilization for the prevention and care of preterm birth and the maternal and newborn health more broadly. Leveraging financial commitments and ensuring these resources are effectively allocated are instrumental in building sustainable health programs. I really do look forward to a continued work together. This is not the end, a continuation from us of our commitment to the preterm birth issues, but also to continue building this movement for a decade of change to follow. Thank you, really. Back to you, Mercy.
Oh, thank you very much, Rajat. And most importantly, for your continued leadership on these issues. We really, really appreciate that. Now, as I close, I had asked us to reflect on how many seconds there are in this webinar, and we all reached 5,400. And just to take you back to two key statistics that stand for me when we talk about the Born Too Soon movement, it says that every 2 seconds, a baby is born too soon. We've been here for 5,400 seconds. That means that ideally 2,700 babies have been born too soon, just in the time that we've sat in this webinar. And another key statistic is that out of every 40 of these babies, one of them, every 40 seconds, one of these babies die. So again, when we go back to the 5,400 seconds, it translates to about 135 of these babies born too soon dying. I hope that is a key data that you figure out even as we talk about this movement. And at this point, I'll just urge you to please find the links to this supplement. Some of them have been put on chat and on screen, and I highly encourage you to share, advocate, challenge, and lead. Every one of us has a role to play. So wherever you sit, you cannot just ignore this conversation. So thank you so much for joining us for this webinar and for staying put. More than 250 of you staying till the end. We really appreciate that. So thank you. And it's been really great to be your host and moderator, and see you on the road ahead. Thank you.